Introduce myself again, Brian Chilelli, and I'll be discussing MCL injuries. We'll go over the diagnosis and treatment options for these injuries. My disclosures are the following. Really, we're going to focus on the anatomy and biomechanics, then dive into the mechanism of injury and discuss the diagnosis, including classification. And then lastly, we'll go over non-operative and operative interventions for these injuries. If we look at the anatomy of the medial side of the knee, really the first layer of soft tissue consists of the sartorius fascia, vastus medialis, and the medial retinaculum. And then we dive deeper to that, and we have the semimembranosus, which has a very robust attachment sites throughout the tibia, as well as the capsule itself, to provide dynamic stabilization to the posterior medial corner of the knee. If we look at the attachment sites of the MCL itself, first and foremost, the superficial MCL femoral attachment is just proximal and posterior to the medial epicondyle. And then the tibial attachment, there's two attachment sites of the superficial MCL. There's an attachment 1 centimeter distal to the joint line, and then there's another 6 centimeters distal to the joint line. And a deep MCL is really a thickening of the medial joint capsule. It's distinct and deep to the superficial MCL, and it has the meniscotibial and meniscofemoral components. Posterior oblique ligament are a series of fascial extensions off of the semimembranosus that merge with the posterior medial joint capsule. This is a cadaveric model, really demonstrating that wide presence of the MCL and the posterior oblique ligament. Other structures that are important regarding the posterior medial corner, in addition to the superficial and deep MCLs, as well as the posterior oblique ligament, include the oblique popliteal ligament as well as the posterior horn of the medial meniscus. All of them provide various levels of stability for the posterior medial aspect of the knee. The most common mechanism of injury includes a valgus stress from either a non-contact or a contact injury. Oftentimes there's a rotational component to this as well. Really, initial workup, like most things in orthopedic, includes x-rays. Sometimes you see these Pellegrini Steata lesions, which are calcifications adjacent to the MCL attachment, usually associated with chronic type of injuries. But really, our workhorse is the MRI to diagnose these after a physical exam, of course. When we talk about a physical exam, really, historically, what we're looking at is assessing the knee in 0 degrees of extension as well as 20 to 30 degrees of flexion. And historic grades have been 1, 2, or 3 based on the amount of gapping of the joint line, 5 millimeters or less, 5 to 10 millimeters and greater than 10 millimeters. And laxity with full extension often indicates a more severe injury, as well as oftentimes a combined injury with the cruciate ligaments. However, the issue is with this historic classification, it's quite subjective, as you can imagine. Trying to determine exactly how much gapping you have is different for each provider. This is a consensus group consisting of Jorge Chala, Rob Laprade, Alan Gitgood, and other knee experts throughout the world. And they really came together to try to create a consensus statement regarding the diagnosis, classification, treatment, and rehabilitation of posterior medial corner injuries. This is a diagram that demonstrates their agreement or disagreement with certain statements. And to the right demonstrates areas in which there was unanimous agreement in the blue. The red designates areas where there was disagreement with various statements. So if we dive further into this and we look at where they were disagreeing at, a large percentage of the disagreements pertain to the classification, these subjective systems, and what kind of prognostic value or treatment guidance do these subjective classifications provide. And as you can see, there was significant disagreement, meaning that they didn't feel that these subjective classifications really helped determine treatment. So with that being said, I do think it's important for us to kind of dive further into our physical exam, as well as other factors to really assess the severity of these types of injuries. We want to assess the rotational components as well, because higher levels of injuries do provide or do cause rotational issues. So we want to perform the anterior medial drawer as well as the dial test. This is a really excellent diagram Dr. Noyes actually put together within one of his chapters of his book, which I would encourage everybody to check out. I would say that, in my opinion, the first degree injuries, it's pretty unanimous how we feel about that. These are very low-grade injuries where we don't really assess much laxity on exam. They may have some pain medially with valgus stress, but it's pretty standard how we treat these with functional bracing. The second degree injuries are really these injuries where you may have a subtle amount of laxity, but certainly have a firm endpoint. And these are treated conservatively as well, which we'll get into. It's these third degree injuries where there's a lot of variation, where this physical exam really plays an important role, as well as other tests, which I'll get to. Especially these grade 2 and 3s underneath of this. And this is where we see a lot of these rotational deformities. These are higher severity injuries, including injuries to the posterior oblique ligament as well as additional ligaments. As a result of the subjectivity with some of these historic tests and classifications, Rob Lepod put together a biomechanical study looking at valgus stress tests. So it's x-rays that are performed with the manual stress to the knee and determining how much gapping occurs. And the conclusion of the paper was that grade 3 superficial MCL injuries resulted in greater than 3.2 millimeters of gapping, while higher severity injuries, including posterior oblique ligament and deep MCL, resulted in gapping of greater than 9.8 millimeters. And this is a x-ray depiction of how that exam is done and what that looks like. Similarly, Dr. Noyes developed an approach to these as well, as is mentioned in his chapter in his book, where he looks at gapping of the compartments at the time of arthroscopy and determine the extent of injury based on the amount of gapping. So I think it's important to note that as surgeons and as clinicians, to really further investigate these injuries for different levels of severity. Really, non-surgical management is the mainstay of treatment for most isolated grade 1 and 2 injuries and a large majority of grade 3 injuries. The goals of non-operative management include bracing, early range of motion, weight bearing. We want to activate the quadriceps and hamstring with a gradual return to activity. Grade 3 injuries oftentimes will require a short time of mobilization to allow the soft tissue sleeve to heal in order to minimize laxity, joint opening, and external rotation of the tibia. And as a lot of these slides, I'm actually referring to a lot of Dr. Noyes' work, and specifically this stick-down method, which he has described, which includes immobilization of these higher energy injuries in order to allow the soft tissues to heal, prevent gapping. And this is followed by a splitting of this cast immobilization to allow some range of motion after the initial healing period, with some touchdown weight bearing, quad activation, followed by a functional brace after a few weeks of healing. Really, the approach to most of these combined MCL and ACL injuries involves rehabilitating the medial knee injury first, so allowing that to heal according to guidelines that I've already discussed. And then this is followed by a delayed reconstruction of the ACL 4 to 6 weeks after the injury, once you have good clinical objective evidence of healing of the MCL. Really, the surgical management is reserved for some isolated grade 3 injuries. The vast majority of these are more chronic injuries where patients have continued laxity and symptoms despite non-operative management, as well as combined multiligamentous injuries. We can further subdivide the surgical management into direct repair of the injured structures. Oftentimes this involves sutures and anchors, augmentation of repair with hamstring, or actual reconstruction with either autograft or allograft. This is a depiction of a reattachment, just utilizing a suture anchor, can be performed at the femoral as well as the tibial attachments. There are some descriptions of an internal brace that can be utilized in conjunction with the repair. In addition, for usually more chronic injuries, there are several descriptions regarding various reconstruction constructs to reconstruct the superficial MCL as well as the posterior oblique ligament. And this is really a study that Rob LaPrade published recently, looking at a augmented repair technique versus reconstruction, and really found no difference. Although I would have to say that the augmented repair did require how it's described, a drill tunnel combined with the repair. If we look at outcomes following these types of injuries, we see rather favorable results. However, as you can see by the levels of these studies as well as the number of patients, we don't really have nearly as much data and outcomes as we do at ACL, just because the surgical management of these conditions is significantly less common than ACL reconstruction. In addition, there's systematic reviews also demonstrating recent favorable outcomes following these surgical interventions. Thank you very much.